Welcome, and thank you for joining the 2020 Virtual Infant Health Policy Summit, the 6th annual summit. I'm Susan Hepworth, Executive Director of the National Coalition for Infant Health, and I'll be hosting today's program. I want to start by thanking our co-hosts, the Alliance for Patient Access and Institute for Patient Access. And I also want to thank our very generous sponsors who made today's program possible: Mallinckrodt Pharmaceuticals, Prolacta Bioscience, Sobi, and Momenta. You'll notice on the live stream page you're currently viewing, there are two boxes, one for question and answer and the other for chat. Some of today's summit segments will feature an opportunity for audience question and answer. If that's the case, at any time during the segment, type in your question in that box, click Ask, and your question will be added to the queue. You can also chat with fellow attendees by using the chat box. If you are on social media, we encourage you to use the hashtag InfantSummit20. As you scroll through the live stream page, you'll also find bios for all of today's speakers. You'll find the agenda and videos and resources from the coalition. We encourage you to download and share those resources. You can also find more resources and information about the National Coalition for Infant Health at infanthealth.org. Now, it's my pleasure to introduce our very first speaker, who will deliver our opening remarks. Julian Nixon is a NICU dad. He's a recognized speaker, a thought leader, and an award-winning STEM educator, and he's coming to us today from South Carolina. Julian, we'll take it away here in just a second, as soon as Julian's ready. Sorry, this is how these live programs kind of go sometimes. But we're definitely excited that everybody is here today. For those who have attended the previous 5 summits, you'll know that we like to gather a lot of policymakers, clinicians, advocates, to really take our message forward, to figure out where are the policies that we can make the biggest impact to improve the lives of infants and their families. So we're excited for this day, and I'm told Julian is ready to go. So Julian, go ahead and take it away.
Good morning, everyone. My name is Julian Nixon. Some of you are joining us this morning from your kitchen, your living room, your home office, or maybe your back porch. Half of you are probably still in your PJs. And maybe, like me, you're reflecting on this virtual gathering and you're thinking yet again, this is a really strange year. I mean, if you really think about it, we're living during a global pandemic, during one of the largest civil rights movements in US history during a presidential election year. So technically, we are living out history. And in your home, you're probably surrounded by family, still looking for a place to have some alone time, but you might be actually feeling alone. I know personally for me, I've felt aloneness before. It was several years ago when my wife first gave birth to our son. Because our son was born prematurely, we didn't have the traditional birthing experience, where the child is born and they're passed around from family member to family member, like the Vince Lombardi trophy after the Super Bowl. Instead, our son was whisked away to an area of the hospital that at the time I had never heard of before. It's called the Neonatal Intensive Care Unit, commonly referred to as the NICU. And I found myself there pulling up a rocking chair to his incubator, reading stories, telling jokes, praying with him, and just observing everything going on around me. I remember the silence that would be there for one moment, and then alarms going off and staff frantically bustling and hustling about. Knowing their level of professionalism, it should have been comforting, knowing that they clearly knew exactly what they were supposed to be doing, but instead it kind of fed into my anxiety. Because you see, even though my wife and I walked away from the NICU, our son did not. They say that the loss of a child is one of the most painful experiences an adult can have, and it's true. That aloneness was heavy, it was heartbreaking. Meanwhile, the anxiety from that experience grew into something known as PTSD, which stands for post-traumatic stress disorder. But today, we have a different story. My wife and I chose to pursue adoption. And a community of support sprung up around us. people who had been relative strangers guided us through the adoption process, answered our questions, and encouraged us every step of the way. And today, we are now proud parents of a young baby girl named Jazara. And there's more. My wife and I decided that no one should have to navigate the NICU alone. So together we developed and released an app called Connect to NICU, which allows families, community partners, and healthcare providers to meet in one place to provide care for that baby in the NICU. And now, here I am today, honored to be welcoming all of you to the 2020 Infant Health Policy Summit. Now, yes, we may be scattered across the country and we may be virtually, but this group, we are hardly alone. Because regardless of whether we are gathered in person or virtual, we stand shoulder to shoulder for policies that make every family's journey and every child's health a priority. Today, you'll hear from parents and healthcare providers, experts, policymakers about a host of issues, things like prematurity, vaccines, RSV, COVID-19, disparities in the NICU, and how gut disorders just might be warded off by the power of human milk. I hope you'll stay with us, ask questions, and offer encouragement through the chat feature. And most of all, I hope that you'll sign off this afternoon with a renewed sense of what we together can do to encourage policies that improve the health and lives of infants and their families across this country, regardless of where they may be or what they may look like. Thank you, and welcome to the 2020 Infant Health Policy Summit.
Some preemies are born months early at extremely low birth weights. They fight for each breath, and they face nearly insurmountable health obstacles. But that's not every preemie's story. Maybe a baby is born from 34 through 36 weeks. Just like preemies born much earlier, she can face jaundice or respiratory problems. Perhaps she has feeding issues. Her mom wants to breastfeed but doesn't have access to a hospital-grade breast pump. The baby struggles to get back to her birth weight. Meanwhile, frustrated and exhausted, her parents face postpartum depression or post-traumatic stress disorder. This baby is still a preemie. What about a baby born preterm at a normal weight? He's so big. How can he be a preemie, family and friends ask? He looks healthy, but may still have complications and require NICU care. And some health plans determine coverage based on a baby's weight. Insurers may refuse to cover certain hospital expenses for this preemie because of his size, leaving his family with crippling medical bills. Yet this baby is still a preemie. What about a baby born preterm but not admitted to the NICU? She is still vulnerable to illness, developmental delays, and health challenges even outside the NICU. And those challenges can extend through childhood, adolescence, and even into adulthood. This baby is still a preemie. Some preemies will spend months in the hospital and face lifelong health problems. But all preemies face risks, and all preemies and their families deserve appropriate health coverage and access to proper care. Because no matter how prematurely they were born or what challenges they face, each of these preemies is still a preemie.
Well, first, I want to thank Julian for those excellent remarks and for all of the work that he has done to take what is a devastating situation that he and his family endured and to turn it into a positive to help other NICU families navigate that very challenging experience. So we're really grateful for Julian for his remarks, and I hope that everybody just enjoyed that video that we were able to see. That's a little bit of a preview of this first topic. So I'm excited to introduce our first segment of today's summit, The Forgotten Preemies, Late Preterm Infants. And I am joined by Dr. Viveka Prakash Zawiza. Dr. Prakash Zawiza is president-elect of the National Perinatal Association and a practicing OBGYN. She's coming to us today from Boston, Massachusetts. We're also joined by Dr. Aaron Sunseth Ross, and Assistant Clinical Professor in the Department of Pediatrics at the University of Colorado School of Medicine. Dr. Ross is also a board member at Feeding Matters, and she's coming to us today from Denver, Colorado. We have allotted a few minutes at the end of this segment for questions, so please be sure to submit those questions in the Q&A box at any time during these discussions. There's no need to hold the questions until the very end. You can type them in as they come to your mind, and then we will try to tackle as many of those questions as we have time for. So Dr. Ross and Dr. Prakash Louisa, thank you so much for joining us. Dr. Ross, I want to start with you first. Can you just define for us right off the bat, what is a late preterm baby, excuse me, and then just talk to us about what some of the complications are that they can face. We saw a little bit of those in the video that we watched just a minute ago, but I want to hear from you what some of those complications can be.
Yes. Well, first of all, thank you for inviting me. And I just wanted to reiterate what the video just very eloquently talked about. So a late preterm baby is a baby born between 34 weeks and 36 weeks and 6/7 weeks, or 6 days, 36 weeks and 6 days. So any baby born under 37 weeks is a premature baby, and term gestation for humans is approximately 40 weeks. And as the video mentioned, some of the things that preterm babies are struggling with include temperature instability. They can have an increased risk of infection, respiratory problems, hypoglycemia, as well as, of course, feeding problems. And that's the area that I really work in.
Okay, thank you. And we're going to come back to that feeding issue in just a minute. But Dr. Prakash Louisa, I want to throw it over to you now. You work with patients and women who are about to give birth. What conversations do you have with your patients who are looking at the possibility of having a late preterm baby? What are those conversations like with them?
It's a great question, and also thank you so much for inviting me to be here today. It's an honor. So as an OBGYN, my job is twofold. I have a pregnant person and I also have an unborn child. And so a lot of the counseling has to be focused on that balance, and especially in the late preterm stage, the conversation is about balancing the risks of continuing the pregnancy because there may be medical or obstetric complications that are leading towards an early delivery with the risks of prematurity. So my job is to make sure that I have that conversation with the patients, explain to the best of my knowledge what that balance looks like and why we might tip in one direction or the other. And a lot of it does involve speaking with our pediatric and neonatal colleagues as well to help explain specifically the prematurity risks.
Okay. And I guess, you know, I should probably tell people the reason that we named this particular segment, the Forgotten Preemies, is like the video outlined. I think sometimes when we think of a premature baby, we think of extremely, extremely small, spending perhaps a lot of time in the NICU. But we kind of forget about these babies who are born a little bit older because they look really healthy and cute. You know, they have chubby cheeks, their coloring is great. So we think, well, I mean, they look healthy, they must be healthy. But we know that that is not always the case. And so one thing that our coalition has tried to do is really raise awareness about this forgotten preterm infant. So Dr. Ross, let me kick it back to you. You're on the board of Feeding Matters. You know a lot about feeding challenges. So talk to us a little bit more in depth about the feeding challenges that some of these infants will face.
Well, as we've been talking about, preterm babies have an underdeveloped neurologic system, and that can affect their muscle tone, it can affect sleeping, it can affect their ability to stay awake, and certainly it can affect their eating. And about 40% of preterm babies who are in the late preterm category will struggle with some feeding problems. It's as high as 60% in a baby who's born at 34 weeks and drops down as the child gets older. Most of the problems that I see when I'm working with these babies in the intensive care nursery include difficulty with staying awake as well as with stamina, and suction, which is the ability to draw the fluid out of the breast or the bottle, is really just developing in that 34, 35, 36 week time frame. So it can be very frustrating for families because, as you said, the baby looks healthy and ready to go home, but eating is the one thing that they are still working on. And I remind families that I work with that eating is the last thing to develop, primarily because it relies on all of the other areas to be fully developed. The other thing that we have to think about is that depending on the circumstances of the birth, we may also need to be supporting the moms. Many of these moms may have had medical conditions that can affect the ability to make enough breast milk. And so we need to think about having them pump or supplementing a baby after a feeding as necessary.
Yeah. I like what you said there, and just to reiterate that, from my understanding, one of the last things that can keep a baby in the NICU is their inability to feed. So while everything else may be good to go, it's the feeding that's going to keep them there in that NICU. Is that right, Dr. Ross?
Yes, that is very common.
Okay. So I want to stay here with you for just a second. So I mentioned that you work with an organization called Feeding Matters, and they have some very good news recently, and I want you to share that with us. This bit of good news is going to go a long way in helping with the diagnosis, and ultimately the treatment of pediatric feeding disorders. So talk to us a little bit about that good news.
Yes, I'm very excited about this as the chair of the advocacy committee. So Feeding Matters is a parent professional organization. We're really dedicated to improving the system of care for children who have feeding problems and their families. And so there are actually two things that I wanted to share with our listening audience today. One is actually an online feeding screening questionnaire, if you will. And I know that, Susan, you have the link for this particular questionnaire, but it was designed by a group of multidisciplinary professionals who work in this area. And our goal really was to improve the early identification through essentially a screening process. This tool has been undergoing a lot of revisions and has been studied fairly extensively. The most recent article just came out in August in the Journal of Pediatrics that shows that with 6 questions, we really can identify children who should be seen for a full evaluation. And one of the best things I think personally about this questionnaire is it actually automatically will adjust for prematurity. So as we've been talking about, eating is really tied to development, and developmental milestones are adjusted based on the prematurity of the baby. And so the website tool will automatically make that adjustment by asking if the baby was born premature. The second really exciting thing that you're talking about, Susan, is that we have worked very hard for several years with a group of our constituents to get the Centers for Disease Control and Prevention, CDC, to recognize that pediatric feeding disorder should be a standalone diagnosis. Over 200 medical issues will have feeding problems as one of the clinical characteristics, but we also know that oftentimes it is being missed. And so we've worked very hard with the Centers for Disease Control, and they have finally agreed that in the next manual that is coming out next year, that pediatric feeding disorder will be a standalone diagnosis. We really think of pediatric feeding disorder as impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill deficit, or psychosocial dysfunctions in families.
Thanks, Dr. Ross. That is great news, and a shout out to all the people who are watching this live stream today who sent letters and comments to the CDC supporting that diagnosis code. So congratulations to Feeding Matters on all the hard work there, and we were excited to have a small part in that. Dr. Prakash Zuiza, I want to go back to you. In your line of work, as you're talking with these new and expectant parents, Do you think that the moms and dads you see are even remotely aware that there is such a thing as a feeding challenge and that it's something they might need to watch out for?
I would say honestly, no. The answer would be no. I think, again, to highlight what you said, I think there is a misconception that these babies born late preterm are more or less normal, and so I think a lot of those nuances about what those babies' needs are not very apparent to these families. And again, that's where, as an OBGYN, I often rely on my neonatal NICU colleagues to help explain what those needs are. And as Dr. Ross, clearly delineated, there are a lot of special issues to take into consideration. So my job is to at least connect the families with the right people and to educate them as best I can as well.
So now putting on your NPA hat, so you're with the National Perinatal Association, and they've done a lot of work around late preterm infants, and they're currently actually revising their late preterm guidelines. So I just wanted to hear from you, what do you expect to see? What are some of the key points in those guidelines? And then, for those watching who don't necessarily understand what these guidelines are, why do we even need to have guidelines in the first place?
Yeah, it's a great question, and I'm very proud of the work that NPA is doing. For folks who don't know, the National Perinatal Association is a very unique organization in that we exist to bring together a multidisciplinary group of experts, advocates, parents, and so these guidelines are meant to reflect that multidisciplinary effort, understanding that the care of all babies, but especially this special group of babies, has to be a team effort, and it has to bring people together who have knowledge from many different realms. And so these guidelines are meant to be a way to do that. Additionally, these guidelines are meant to sort of standardize the care of these babies because it varies from hospital to hospital. It may even vary within a hospital depending on which provider is in the NICU. And the reason for that is because this population of babies hasn't been very well understood. And as we're getting more and more information, we can refine our knowledge and these guidelines. So the guidelines exist to address essentially four phases. One is the in-hospital phase. Then the second is the transition to home, which we all know can be extremely stressful for families. Then the short-term follow-up, and then long-term follow-up. And again, each of those four phases has input from experts across the sphere, and was based on a summit actually that brought these people together in person to develop these guidelines. And Susan, I know that you have the link to the guidelines, and I hope that folks do take a look and appreciate all the hard work that went in.
Yes, and I'll actually give those URLs and information here at the end. Dr. Ross, I think I want to end it with you. How do you help the families that you work with understand the challenges, the variety of challenges that their babies might face, even when they're born late preterm?
So I work a couple of days a week in intensive care nurseries here in Denver, Colorado. And as I have mentioned, it's really frustrating for families when feeding is the last thing, and it's something that we all do so easily. So people struggle with understanding why is their baby not able to do it. So I remind them that a human gestation period typically is 40 weeks, plus or minus a couple of weeks. And there is a reason for that, that if we were all supposed to be born early, even though we're perfectly formed and cute, that we would have a gestation period that is earlier than that. And so there's a lot that's really happening in that 34, 35, 36 week gestational period. And so when you, first of all, think about it in that way, that can be helpful. The other thing that I remind them is that eating is like other developmental tasks, and it really relies on the ability of the baby to stay awake, to have the muscle energy, the neurobehavioral maturation. And so just like walking, we don't know when it's going to happen, but with healthy preterm babies, we know that the vast majority of time it's going to happen. If a baby is going home and eating is a struggle, I remind people that in development, things should get better. and consistently be getting better. And so if you're at home and you're still struggling, you're stressed during meal times, I encourage you to talk to your physician, go online to the website, take the questionnaire, get help, because eating oftentimes starts off a bit stressful for these babies. Hopefully with a lot of support, babies will be eating and enjoying it as much as you and I do.
Great. Okay, we have gotten a couple of questions in, and one actually, Dr. Ross, you kind of just addressed, so I kind of want to hear from both of you a little bit more on this, but someone asks, how can we support mothers whose babies are experiencing feeding issues? So Dr. Prakash Suiza, do you want to go first?
Sure. That's a really great question. And my approach to anything that involves supporting a new mother or a new parent is to approach it with non-judgment and to acknowledge that this is a stressful time, and to acknowledge that every baby is different, and whatever choices are made for that particular baby and that family are going to be the right and the best choices for that baby and that family. We see a lot of our mothers struggle so much, especially with these late preterm babies, with the feeding, with breastfeeding, and we know that that can create tremendous stress, and women put a lot of pressure on themselves, and we can see that lead to a lot of postpartum anxiety and depression as well. So the approach has to be gentle, non-judgmental, and with the focus on making sure that the baby and mom are as healthy as they can be.
I like that, gentle and non-judgmental. I think those are two good things right there. Dr. Ross, anything you want to add?
Well, I would like to just remind everyone that eating is something that is developmental, as I mentioned, and feeding our baby is the thing that we do the most in terms of time in the first year, more than anything else. We feed our babies for more minutes of the day. So it can be very frustrating, and moms need support, and we need to try and figure out why eating might be a challenge for the baby, and to reassure moms in some cases, but also to provide the support to help the baby do better and for that experience to be more enjoyable.
And I think we'll just have time for one more question so we can keep our schedule on track. The question is, what can advocates and providers do to help families know how to recognize feeding issues? So Dr. Ross, you talked about the feeding questionnaire, and you can talk a little bit more about that if you want. And I'll let both of you chime in. Dr. Ross, do you want to go first?
Well, I really want to encourage people to go to the website, take a look at the questionnaire. As I mentioned, it really has been designed to pick up when a baby's eating behaviors are not appropriate, and it actually goes all the way up through age 3. And so that, I would say, is where I send my families. And as I mentioned, we have the psychometric data that shows that it's accurately identifying children who should go on and receive a multidisciplinary feeding assessment.
And Dr. Prakash Suiza, do you want to add anything?
Yeah, I would also, I think that's great. And we rely on our advocates to help families connect with the right resources. And the NPA guidelines are also a great resource for this. I should also have mentioned that the guidelines are divided up for guidance both for healthcare providers and for families. So there's resources for both. And within each section, there is information about screening specific to all of these areas, but feeding is one of the areas. And so those guidelines can also serve as a useful guide to screen for these issues, and then also how to actually get support for them.
Great. Well, if you want to learn more, you can visit nationalperinatal.org, search late preterm, and that's where you will be able to find more information from them on late preterm infants. And if you go to feedingmatters.org, right there actually on the main screen, there was a big purple bar, and that's where you can find the link to that questionnaire. So I really want to thank Dr. Ross and Dr. Prakash Suiza for joining us today so that we don't forget about this very important population of our preemie community. So thank you so much for joining us.
Thank you very much.
Thank you so much.
Well, our next segment is going to be hosted by my colleague, Amanda Conshafter. Amanda is the Communications Director at the Alliance for Patient Access. So Amanda, I will go ahead and turn it over to you to get started.
Thank you, Susan, and thank you for the opportunity to moderate our next discussion, RSV and COVID-19, double trouble. So as with the previous discussion, we have allotted a few minutes at the end of this panel to answer questions from the audience. And you're free to enter those questions at any point during the conversation using the Q&A feature on your screen. So please feel free to do that. So for today's talk, I'm joined by Dr. Suzanne Stabler, Policy Advisor for the National Coalition for Infant Health, and also clinical professor at Emory University School of Nursing, as well as Crystal Baker, a patient advocate and a mom who has a personal story on this topic. So thank you both for joining us today. Now, in a matter of weeks, we will be officially entering RSV season, when hospitals and doctors' offices across the country will begin to see an influx of infants who are fighting what's known as respiratory syncytial virus. So Suzanne, I want to start with you. If you're a parent and you're looking at your child and you're wondering, could my child have RSV? What are those telltale signs to look for?
Well, Amanda, for most parents, RSV starts off as symptoms of the common cold. So they may have, babies may have a runny nose, they may have a low-grade fever, they will start to have more and more nasal congestion. And as RSV progresses, then they also will have progression of respiratory distress. So it'll be harder for them to breathe. And when they start working harder to breathe, then they stop doing other things such as they want to sleep more and they stop eating.
Okay, good to know. So Crystal, I know that your infant son, Cameron, contracted RSV earlier this year. Does Suzanne's description match your own experience?
Yes, it sounds all too familiar. My son Cameron was 3 months old when I went back to work, and he started in daycare. And by the end of his first week, there was a flyer on the door that said that somebody at the daycare had RSV. Just a few days later, I noticed that Cameron was sneezing and congested and fussy, and he didn't seem like himself. Something wasn't right. And by that evening, his symptoms were a lot more severe.
So Suzanne, I'm curious, what is next for infants like little Cameron when they start to experience these symptoms? And as Crystal said, it goes from seeing the child have symptoms that look a little bit maybe like a cold to just having that intuitive sense that something's not quite right. This is something more.
Right. So usually what will happen for parents is they will call their pediatrician. Sometimes the pediatrician, if it's during regular office hours, can fit them in. Many times, if their panel is already booked for the day with patient appointments, they will send them to urgent care or the emergency room. So many of these infants and parents, their first initiation of care is in the emergency room. And then you will have a subset of these infants who need to be admitted because they are working so hard to breathe. They can't maintain their oxygen saturations. They now require respiratory treatments. They require oxygen. And for really high risk infants, like premature infants, or as current research has shown us, term infants who are less than 6 months of age, they many times progress to requiring hospitalization. And that can be really scary for parents. Crystal, it sounds like your son may have wound up in the hospital as well.
Yes, he did. When he was originally showing signs of RSV, I did take him to his pediatrician. She was able to fit us in right away. And the RSV test that she gave him at the office came back negative. However, our pediatrician strongly suspected that he did have RSV. We were just catching it very early. She made sure that I had a nebulizer and prescribed him with saline and albuterol. And less than 36 hours later, he wears an owlet sock at night that tracks his heart rate as well as his oxygen levels. And within just a few hours, his oxygen levels kept falling below 80%. And he was having rapid breathing that was exceeding 60 breaths a minute. I didn't get any sleep that night. I was just holding him, trying to make sure that he was okay. Finally, 4 in the morning, my husband and I called our pediatrician, and she strongly recommended that we take him to the ER. We got to the ER and they tested him for RSV. And at that point, that test was positive.
So, Crystal, I think any parent who's ever taken their child to the emergency room knows how terrifying that can be. And hearing your experience, I can't help but think this must have been very scary for your family.
It was, and my family was lucky. My son survived, but the experience was heart wrenching and something that I hope that we never have to go through. But also, I hope nobody else has to go through this again either. My baby was 3 months. He was about 10 pounds, and he was on oxygen for 5 days. His fever continued to spike, and when we went to the ER, he was severely dehydrated. It had been 14 hours since he had eaten. It had been 7 hours since his last wet diaper. And I just had a knot in the pit of my stomach because I was watching them have to get an IV into him and having to poke him multiple times. And I felt helpless that I couldn't do more for him. But the worst part was RSV took away breastfeeding from me and Cameron. Those 5 days in the hospital, I was unable to breastfeed him. I didn't have an oversupply. So those 5 days just ended our breastfeeding journey early. And that was something I never expected. And it's still really hard for me to accept.
So I think what strikes me as I hear your story, Crystal, is that scenarios like this can be avoided. So there is preventive treatment for RSV known as palivizumab that can protect infants like your son. But Suzanne, as you're well aware, sometimes health insurance companies can make it hard for families to access this treatment. And so I want to share a few data points actually with our audience. So as reported by the Institute for Patient Access earlier this year, commercial insurers actually refused to cover preventive RSV treatment for 40% of preemies who were born between 29 and 36 weeks gestation, so 40%. Then when we look at a second set of preemies, those born before 29 weeks gestation, so very early, or born with certain heart or lung complications, there we saw the commercial insurance rejection rate at 1 in every 4. So Suzanne, after hearing Crystal's story and your own account of what RSV can do, can you help us make some sense of this? I mean, why would insurers reject prescriptions for preventive RSV treatment for any infants of any gestational age?
Well, Amanda, it all kind of boils down to policies that have been developed by the American Academy of Pediatrics that dictate payer behaviors. So the data point that you just talked about, where 1 in 4 infants born less than 29 weeks, that absolutely should not be happening, because those babies, per those guidelines, should absolutely be receiving the preventative treatment. Those are the highest risk patients that we have. I think superficially, insurers think that they are saving the system money over the long run. But when you have an infant who then is subsequently hospitalized, it's kind of like a gamble. And so the cost of ER visits, pediatrician visits, hospitalization, oxygen therapy, a pediatric intensive care unit stay, those exponentially increase the risk and the cost. And subsequently, what we have found through research is once these babies have a severe case of RSV, they then have chronic health conditions such as persistent wheezing that require increased levels of care throughout early childhood. It goes back again to those really premature babies should absolutely get the preventative treatment. And for babies who fall in what we call the gap baby area, that is 29 to 35 weeks, we as healthcare providers really need to have crucial conversations with those payers in order to get them to understand that these babies do need the preventative therapy.
Suzanne, let me follow up on that just for a second. So I'm wondering, in the occasions where coverage is not provided, I suspect there is a discrepancy there. I mean, I would imagine that families that can would pay for the treatment out of pocket so that they can protect their child. But of course, that's not an option for every family. So what effect does that have on health and disparities, if you will?
So it's a huge issue, Amanda, because when you consider that about 65 to 70% of the babies born in the neonatal intensive care who then go to the neonatal intensive care unit have Medicaid as their primary payer, it actually advances or increases the health disparity concern, because you have parents who are already at risk because of their socioeconomic status, because of the health disparities, because of potentially their environment where they're living, and other things that we know automatically increase the risk for severe RSV disease. And these parents don't have the resources to even consider paying for prophylaxis out of pocket. And so we just widen that disparity gap.
It's interesting. So it sounds like the policy is really sort of separating infants into the haves and the have-nots. So I just want to make a note to our audience. The report card that includes the data points I just made is in the resources section on your screen. So that's free to download, and you're welcome to share that online with your networks as you would like. Now, something is a little different about this year's RSV season, and that is, of course, the presence of COVID-19, the novel coronavirus. And Crystal, I wonder if you would share a little bit, how did the risk of COVID-19 and the many precautions that we in the healthcare system are taking, how did that shape your experience with Cameron and his experience with RSV?
Yeah, it was terrifying. When Cameron was sick, this was March 20th. The country had virtually shut down because of COVID, and we were having to take him into the ER. And that was honestly the last place that we wanted to go. And even having him admitted in the hospital was the last place we wanted to go. He was taken in an ambulance from the ER to the hospital, and I had to watch them strap him to a stretcher, and then they wouldn't let me ride in the back of the ambulance with him. That was the longest 20-minute ambulance ride of my life, and just so hard knowing that he was back there alone and without me. They also only allowed one parent at a time, and that meant that one parent had to completely leave the hospital before the other parent could go back in, which meant that 10 to 15 minutes, my son was left alone when my husband would come to give me a break so I could go home, I could shower, I could sanitize Cameron's things, and then I could come back and continue to stay with him. It also was tough that, one parent was having to make all of the decisions. We couldn't be there for each other. There was just a lot of isolation and anxiety just with the whole experience, especially with so many people coming in and out. And the hardest part was when we would return to the hospital and they would ask us every time the questions, have we been around COVID? Our answer was no, but we honestly didn't know. We didn't know if we were being exposed to COVID in the hospital during that hospital stay.
Suzanne, is there a link between RSV and COVID?
I don't know that we know definitively that there's a link, but we do know that they come from similar families of respiratory viruses. So again, those infants who are most susceptible to severe RSV disease are also going to be the same infants who are susceptible to contracting COVID and having complications and long-term sequelae from COVID-19 infections.
Okay, makes sense. So as our time together winds down, I want to ask one final question. Obviously, we're here today as part of the Infant Health Policy Summit. what can policymakers do to protect families from experiences like Crystal's?
Ultimately, as policymakers, we really need to push to have babies receive the prophylactic therapy. And so many times, especially if you're a provider like myself, that means spending the time to write letters or get on the phone with insurance companies to make the case for this patient to get the prophylactic therapy. We also need to make sure that we educate our families about minimizing exposures. And that may mean that they kind of stay home and are pseudo quarantine during RSV, COVID, flu season in order to protect their babies.
Thanks, Suzanne. All right, well, I know we have a few questions from our audience. So let me take a look at some of those. All right, so here's a question for you, Suzanne. How can parents differentiate between RSV and COVID?
I don't think there's a way to differentiate as a parent, even as a healthcare provider, because everything is so similar. You have fever, you have the respiratory symptoms. And so I don't think there could be a way to differentiate. I think the biggest thing for parents is to really pay attention to COVID exposures. So in your small little network of friends or family, if anyone has had a COVID exposure, then if your baby gets sick, the likelihood that it is COVID versus RSV would probably be higher on the COVID side. But again, with any of those types of respiratory symptoms where your baby is breathing harder, faster, they stop eating consistently, they have a fever, your baby needs to be evaluated because it really is difficult to tell exactly what without testing.
Okay, and let me follow up on that. So you talked about taking precautions and maybe staying home. Another question we have is about prevention. So RSV season, COVID, what more can we do to prevent exposure for infants to all infectious diseases? So what are some of the other things parents can do? And in particular, I'm curious, parents who may have older children in the home. So if it's not just the infant, what do we do there?
Well, one of the things providers try to educate parents on is good hand hygiene. It's amazing to me with all of the COVID guidance coming from the CDC. Early on, if you guys will remember, in March and April, it was like cover your mouth and face and don't touch your face. And because somebody told me I couldn't touch my face, it was remarkable to me how many times I was touching my face or my nose or something like that. So good hand hygiene, making sure that even your older siblings, that they wash their hands before they touch their younger brother and sister, and then they gel their hands afterwards, making sure that toys and hard surfaces are disinfected and cleaned as often as possible will also help with the spread as well.
Okay, very good. All right, and maybe just one last question. We talked briefly a few minutes ago in the earlier panel about feeding. We'll talk more about human milk later on. What are the benefits of breastfeeding as far as mitigating the possibility of babies contracting RSV?
Well, we do know there is some protective mechanism because if mom has any level of maternal antibody, those will absolutely cross breast milk. And baby gets the benefit of that, especially in those first couple of months of life. We also know that if babies do contract RSV, they tend to have less severe disease if mom has been breastfeeding, just because of the immune boost that babies get from maternal breast milk.
Very good. All right. Well, Crystal, Suzanne, thank you for joining me today. We'll end this segment with a video from the National Coalition for Infant Health that explores the access challenges facing infants who need preventive RSV treatment. Thank you.
Parents of premature babies face a lot of challenges, accessing medicine that protects their baby from a deadly respiratory virus shouldn't be one of them. But national data shows that it is. Commercial insurance companies are denying coverage for babies who need preventive treatment against RSV, or respiratory syncytial virus. It's the leading cause of hospitalization for babies under age 1. For preemies born at 29 to 36 weeks gestation, commercial insurers reject 40% of claims. They even reject 1 in 4 claims for severely premature infants. What happens when fragile infants can't get preventive treatment? They may contract RSV, develop bronchiolitis, require hospitalization, and need ventilator support to keep breathing. Not all infants survive. That's why clinicians prescribe preventive treatment in the first place. Premature infants deserve protection against RSV. It's time to stop misguided policies from putting these vulnerable babies at risk. Learn more at infanthealth.org.
Well, I just want to thank my colleague Amanda and also Suzanne Stabler and Crystal Baker for that really informative discussion. A special thank you to Crystal for sharing what to her is very personal, and it was a very challenging and stressful time in her life. And I know that she's happy to be able to share that story to try to ensure that other families don't have to go through what she did. Again, if you want more information we have a lot of RSV resources on our website. You can visit infanthealth.org, click the resources tab, and you'll see a tile right there. If you click on it about RSV, we have lots of videos, papers, one-pagers, fast facts documents, really all you could need to know about RSV you can find on our website there. And just as a reminder to parents, you know, that season usually starts around the month of October, so it's right around the corner. Today, we are honored to hear remarks from Congresswoman Kim Schreier from the 8th District of Washington State. She is the author of the Vaccines Act, but she's also a pediatrician. Unfortunately, due to some last-minute changes in her schedule and some committee hearings that got placed on there last minute, we couldn't have the Congresswoman live with us today, but we are grateful that we were able to pre-record some remarks and some question and answer with her.
Hello, everyone at the Infant Health Summit. I'm Kim Schreier, representative from Washington's 8th Congressional District, and also a pediatrician, which is part of the reason I'm speaking with you today. I wanted to talk about how important immunizations are. After all, I've spent my life giving immunizations to protect the patients that I take care of, but also about the threat of vaccine misinformation. When I just first came to Congress back in January of 2019, I was soon met by the reality that there were measles outbreaks across the country. And it seemed like the perfect opportunity for a pediatrician to step up and say, you know what? This is a consequence of misinformation, people not understanding vaccines and being afraid to take them. And so I worked across the aisle with Dr. Burgess from Texas, and also with my colleague Patty Murray in the Senate. Together with them and with the American Academy of Pediatrics and the CDC, we created the Vaccines Act, vaccine awareness campaign to champion immunizations nationally and enhance safety. It's a mouthful. But the bottom line is that the purpose of this bill is to go and find areas where there is under-vaccination, and then set out to find out why. Is it because there's no clinic in the area? Is it because a doctor retired? Is it because there's a particular community that is concerned about vaccines? Or is it because of online misinformation? And then whatever the reason is, you take the right tool and fix it. And what particularly concerns me is the rise in online anti-vaxxer misinformation, because this is hurting us with routine childhood vaccinations, and none of us want to see a reemergence of things like measles, polio, diphtheria, but also this in the context of where we are right now with COVID. And so based on my vaccines bill, we now have another bill called the Community Immunity Act that I've done with Lauren Underwood, nurse and member of Congress from Illinois, because we want to make sure that we treat this right, that we get good evidence-based information out to the people in this country to help them feel comfortable with whatever vaccine eventually gets approved. This is not about championing a vaccine before it's approved. It's not about cheerleading without data. This is about building trust with the community. It's about addressing the fact that right now 30% of people say they are not willing to get a coronavirus vaccine, even if it is free today. This is about building trust, letting the public know that we will be looking at the data and we will not recommend something that is not safe and effective. And that is why we did the Vaccines Act and now the Community Immunity Act. There's another thing I've been concerned about, and I think you share this concern, which is that right now during the time of COVID, people have been staying home correctly, but they've also been afraid to go out and see their physicians, which means children are missing their well child care and they are falling behind on vaccinations. They are falling dramatically behind. And we need to make sure that doesn't happen, because on top of COVID, we really don't need an epidemic of whooping cough or measles again. And as you know, because this is your specialty, as you know, we are only a few vaccinations away from having an outbreak. So I am delighted that you share my priority of making sure that our children and our communities are vaccinated, that we develop a safe and effective and trusted coronavirus vaccine, and that we build trust with the public, both about the coronavirus vaccines and about routine childhood immunizations, because we need to take this rhetoric back from the anti-vaxxers. We need to communicate good evidence-based information and make sure we win the hearts and the minds of the American public. I will take your questions, and thank you so much for having me today.
Thank you so much, Congresswoman Schreier, for those remarks. The first question I have is, what can advocates and those watching today do to help ensure this legislation becomes law?
Now, this is about the Vaccines Act, and I am so excited, as you heard, to be able to take on the issue of vaccine hesitancy and under-immunization, figure out why it's happening in different parts of our country, and then address it. And the one thing that you could really do is call your own representative and call your senators and ask them to take a look at this bill and support it, because of how important it is for childhood vaccinations and for the prevention of an outbreak of more diseases in our communities. It is time to combat anti-vaxxer rhetoric online. Thank you.
Okay, the next question is, what are your thoughts on how COVID has impacted babies and children getting their vaccines? I know you spoke about that a little bit before, but can you elaborate on that?
Well, I think we've all seen that because of the coronavirus pandemic, people are really not going out. They're afraid to go to their doctors and get care because they're afraid they'll get infected there. The downside, though, is that children are missing their vaccinations. And when that happens, we could end up with another epidemic or pandemic superimposed on COVID, and we can't let that happen. Look, none of us want to go back to a time with meningitis, pertussis, measles, mumps. We need to make sure our children get vaccinated. Part of that is making sure that schools still insist on getting children's immunization records up to date, even with virtual schooling. And the other is making sure that we reassure the public that it is safe to go and visit your doctor. Finally, a lot of pediatricians are making special efforts to have a different setting for administering vaccinations. Since so many children are asymptomatic, it's really hard to separate sick from well children and guarantee that people will not be exposed to coronavirus. But we've seen pediatricians doing clever things like setting up tents outside their clinics or even doing drive-by vaccinations. And those are the kinds of efforts that will keep our children vaccinated and healthy, and our communities healthy as well.
What perspective do you bring to Congress as a physician?
Boy, I am honored to be the only woman doctor in Congress right now, and it brings a lot of different perspectives. One of those is about women's health. Another is about vaccinations and how important they are. But right now, one of the biggest contributions I can make is really being a guiding voice on how we respond to coronavirus and how we combat this pandemic. We need a scientific, evidence-based way to wrap our hands around this. We need consistent messaging that really should be coming from medical professionals, public health experts, or physicians to guide this policy. And we need to make sure that everybody's on the same page. Things like wearing a mask and keeping your distance from other people, not going to crowded settings, those should not be partisan issues, and everybody in this country needs to be on board if we're going to take this on and do well together. So what I have done as a member of Congress is things like anticipating that if we don't have free COVID testing, people might not get tested because of cost. You'll never know if they're infected, and then they can get other people sick. And so I proposed and we passed the no-cost coronavirus testing bill as part of one of our big packages. In addition, we knew that people would not want to go see their doctors, like I just talked about with vaccinations. And so we instituted telehealth, healthcare at home, so that people could still see their doctors and doctors' clinics could still stay open, but that these visits could happen virtually. And finally, I have partnered with my caucus to join many of them in communicating with their constituents about how we should be approaching this pandemic. I am excited to work on the next phase in testing and tracing and how important that is. And frankly, the holy grail next, well, two holy grails. One is a coronavirus vaccine that is safe and effective that we can roll out to the whole American population. And the other is a quick at-home test that would keep asymptomatic people home so they don't spread it to others without knowing that they're doing it. Thank you for that question.
So our last question for you today is, do you have any words of advice or encouragement to the frontline healthcare workers, especially those that are working with our most vulnerable infants and babies?
I will give a general thanks to all of our frontline workers and healthcare workers, both in and out of the clinic
and
setting.
I'm going to introduce the
because right now
video,
is a particularly dangerous time to be at work, and I know that every day you put your health and your lives at risk going to take care of your patients. And I want to thank you for that effort. I want to thank you for being our heroes, and we want to help in any way we can. So thank you for having me today, and I'm sorry I couldn't be with you in person.
Well, thank you so much to Congresswoman Kim Schreier for joining us today and for delivering those remarks. We're going to go ahead and see a short video from the National Coalition for Infant Health. Hepatitis C is a virus that progressively damages the liver, leading to scarring, cirrhosis, liver cancer, or even death. It's often considered a disease of the baby boomer generation because hepatitis C affects 1 in 5 senior citizens. But recently, hepatitis C has also become a threat to an unexpected and especially vulnerable population: pregnant women and their unborn children. How did this happen? In part, it's because of America's opioid abuse epidemic. Increased use of heroin has caused a resurgence of hepatitis C, which can be transmitted by sharing needles. Heroin users who contract hepatitis C can spread the disease to spouses, partners, or household contacts. Women who contract the disease before or while they are pregnant experience double the impact. In addition to battling the condition themselves, they may also infect their unborn baby. Cures for hepatitis C are available now, but they have not been proven safe for pregnant women. It is possible to prevent mothers from transmitting hepatitis C to their babies. We must first identify women of childbearing age who have hepatitis C and cure them before they become pregnant. But that's no simple task. Several barriers can stand in the way. To reduce expenses, some health plans and state Medicaid systems require a multi-step approval process. It can include medical tests and extensive paperwork. Others require that hepatitis C cures be prescribed by a medical specialist, making access difficult for patients who may not live near one or may need to wait for an appointment. Even worse, many health plans and state Medicaid systems provide coverage only for patients who have advanced liver damage. There is no FDA-approved treatment for hepatitis C in newborns. Therefore, If infected women are not cured before becoming mothers, their babies may contract the disease. Policymakers should adjust their coverage rules to better protect women and their unborn babies before it's too late. As mentioned, we have a lot of great resources on infanthealth.org. You can also find that video there and visit our resources tab. We're going to now see a short video from one of today's sponsors of this event. And following that video, we will take our first break of the day and we will convene back here at 1:05 p.m. Eastern Time.
Being a mom has been probably my deepest desire of my life and the thing that I've looked forward to the most. My husband Josh and I live in Tuscaloosa, Alabama. We have 4 living children, and the oldest is Liam, who is 10, then Asher, who's 8, and then we have Lucy, we say Lucy's in heaven, and then Nora is 4, and Callum is 2. In 2012, we found out that I was pregnant with our 3rd baby. We were really excited, and we just kind of expected another normal pregnancy like our 2 previous ones. So at 9 weeks, we went in for our first ultrasound, and the baby looked perfect, but the doctor came in and said there's a problem with the blood work, and you have tested positive for anti-Cal antibodies. And he said that it could be very dangerous for the baby. As a mother, hearing that your baby could be in danger is probably your worst fear. It's a very helpless feeling. Our next appointment was at 17 weeks and 6 days, and I said I really would like an MCA scan to check for fetal anemia. They did the MCA scan, and there was kind of this hush that fell over the room. And I knew something was wrong. She was incredibly anemic. So they scheduled an intrauterine blood transfusion for the very next morning. Basically, I never felt Lucy move after that procedure. Not ever. Lucy passed away on February 8th, 2013. Josh and I were not ready to give up on our dream of a big family. We both desperately wanted more children. So we did some more research and learned about other treatments. And we found out that I was pregnant at the end of 2014. At 17 weeks, we discovered that we were having another baby girl, and that she was Cal positive and so would be attacked by my antibodies. The doctor who treated me was extremely thorough with the monitoring. He would do weekly, sometimes more than weekly, MCA scans to check the baby for anemia. And as soon as she started getting anemic, he did the first intrauterine blood transfusion. It was perfect timing, it went smoothly, and she was born at 38 weeks, totally healthy. 2 years after Nora was born, we were fortunate enough to welcome another baby into our family. Our son, Callum Joseph Thomas, was born after following the same treatment plan. Going into both of my pregnancies with Callum and Nora, we knew that it came with huge risks. It came with risks for the baby, and I knew that I would have to go through a lot of intense medical interventions, and I did. But we feel thankful every single day for the incredible medical care that we were given. Something I would love would be for all the families experiencing this to have the medical treatment that I had with Nora and Callum, or even better, to have better treatments that don't involve the risk and the interventions that we had to go through. I want other families to know that hope is out there. Hope is possible.
Welcome back, and thank you for joining us for the last half of today's program. As a reminder, we encourage you to share on social media using the hashtag InfantSummit20. I am pleased to be joined by a few experts who will help us understand more about our next topic, which is COVID-19 chaos, isolation, disruption, preterm birth reduction. Due to COVID-19, many new and expectant moms are facing isolation. Babies and children are missing out on critical vaccines, a disruption to their vaccine schedules, as we just heard from Congresswoman Schreier. And we've also heard some anecdotal evidence suggesting a potential reduction in preterm births. So here to talk about it, first we have with us Becky Seifer. Becky is the 2020 president of AHWAN, the Association of Women's Health, Obstetric, and Neonatal Nurses. Becky's coming to us today from Tacoma, Washington. We are also joined by Christine Tester. Christine is a mental health peer specialist and a family advocate with Hand to Hold. Christine comes to us today from Austin, Texas. And lastly, we're joined by Dr. Mitchell Goldstein. Dr. Goldstein is the medical director of the National Coalition for Infant Health, and he's a professor of pediatrics at Loma Linda University Children's Hospital. And Dr. Goldstein comes to us today from the greater Los Angeles, California area. So thank you everybody for joining us, and we will go ahead and get started. Christine, I want to start with you. And what we're gonna do is we're gonna first tackle isolation, and all three of you are gonna have a chance to talk about that. And then we're gonna tackle disruption. Everybody will have a chance to weigh in, and then we will tackle the preterm birth reduction, and everybody have an opportunity to weigh in. So Christine, I wanna go to you first. We're gonna tackle isolation. Talk to us about what many new moms and families have been facing as it relates to isolation since the start of the coronavirus.
Sure. Well, thank you, Susan, for inviting me as a parent voice to represent families here. I know we don't have much time, so to answer your question, we all know that pregnancy and childbirth are typically a time for celebration. Pregnancy during a pandemic has brought unprecedented fears, anxieties, and restrictions that have had a huge impact on all families, whether it's multiple feelings of loss relating to missing out on traditional reunions and celebrations, for example, baby showers, increased fears about getting sick, so limiting exposure by not going out, possibly experiencing anxiety when you have to go out for scheduled appointments, and maybe enforcing social distancing on yourself and other family members. All of these lead to layer upon layer of loss and isolation. People typically come together to welcome a baby into the family and to celebrate with others, but with restrictions on visitations in the hospital, with the exception possibly of a birthing partner, and then post-discharge not wanting a newborn to be exposed, especially if that baby has been born premature or is medically fragile, and means that this period has been spent connecting only virtually sometimes, if at all, with others.
Thank you for that, Christine. Becky, I want to go to you next, and I'm glad that we were able to get you in. I know that you're in a building right now that didn't have very good Wi-Fi, so that's why we see your headshot up there and not you there live, but we do have you on the phone, which is great. Becky, we know that perinatal mood disorders are the #1 complication of pregnancy and postpartum. So can you talk to us about how isolation has further amplified those perinatal mood disorders?
Yeah, thank you, Susan. I appreciate it. Again, I apologize for not having adequate internet capability in this particular building. So, you know, the old adage, it takes a village to raise a child, really comes into play here. You know, historically, people use their support systems to assist with, the workload. And today, that level of care from family and friends is disappearing, not only just because of society changes, but also what's happening with COVID and its need for social distancing. You know, mental health is a critical part of patient-centered care. Isolation increases that risk of perinatal mood disorders. So prior to COVID, perinatal mood disorders impacted 1 in 7 patients. Now we have to add self-isolation to further compromise an already very complicated situation, especially when we're talking about high-risk pregnancies and bringing newborns home. We must not lose focus on a patient's mental health. You know, so much information can be gleaned by simply asking a patient, how are you doing? watching for cues that alert you to a problem, and using depression screening tools throughout pregnancy and postpartum, even at well baby visits. We can't wait for the data to show that the problem is worsening. The time is now to make mental health a priority for the family unit.
Great, thank you, Becky. Dr. Goldstein, I want to go to you next. What are you seeing with NICU families right now as it relates to isolation?
I think what you're seeing with respect to the infant families is a lot of confusion. Rules change on a day-by-day or a week-by-week basis in terms of what's allowed and what's not allowed. Visitation has really been affected. So on the one hand, the families are told during the preparation process of their antenatal visits that visitation will be one way, and then when the baby winds up delivered and in the NICU, things are completely different. The restrictions can be very severe. Oftentimes, only one parent can visit a mother or a father, perhaps only one parent per day, perhaps for only a few hours per day, and almost never together. This is disruptive. This is causing a great amount of stress in the family. And should one of the parents be COVID positive, it may mean that the family can't visit at all during the entire course of the baby's hospitalization. I think that as we go further into this and as we start to step out, as there tends to be a drop nationwide, we will see differences and improvement in this pattern. But for now, the only thing that is normal is the amount of confusion that we continually see.
Thanks for that, Dr. Goldstein. I really think that the theme we saw here as it relates to isolation is definitely the mental health component. And earlier in today's program, when we heard from Crystal Baker, whose son was hospitalized with RSV, I know she very much felt that isolation as well. That kind of loneliness. Her husband was unable to come in there, and her baby, in fact, had to be left alone for sometimes 15, 20 minutes at a time when they were making that switch between the parents. So thanks for your insights on that. We're next going to tackle disruption. And Becky, I want to turn it back over to you for this. We've talked about it a little bit today. We heard from Congresswoman Schreier about it as well. And that's this disruption, as we're calling it, the disruption to the vaccine schedule. Becky, tell us a little bit more about that.
So what we have to understand just about vaccinations in general is, this is a global problem. It's just not here in the United States. The WHO and UNICEF recently talked about a decline in the number of children receiving vaccines due to disruptions in not only the delivery, but the uptake of immunization services in 2020. So, in fact, this very same press release stated that the likelihood that a child born today will be fully vaccinated by the age of 5 is less than 20%. This is going to be the first time in 28 years that we may very well see a resurgence in these types of diseases. But I'd be remiss if I didn't really mention, the maternal aspects of vaccinations, specifically influenza and Tdap. They're an essential part of OB care, offering critical protection to women and their fetuses against these particular diseases. And so, again, because of the delivery of services, this may also be disrupted from the maternal aspect. I'd like to kind of alert, those of you who are listening in that, first, I'm very proud of the organization that I am president of, A1, has joined with other organizations such as ACOG, ACNM, and AAFP in publishing a call to action related to vaccinations, which is even more vital during this pandemic. So I encourage you to visit a1.org for educational resources geared towards both clinicians and patients.
Becky, thanks for that. And yeah, we've kind of talked about the vaccine schedule disruption as it relates to infants and children, but you're absolutely right to tie in that maternal component of it as well, because it's definitely impacting that too. Christine, you're in NICUs and hospitals, you're working directly with families. What are you telling them about the importance of keeping up with their children's well visits?
Thank you. Yes, so the population I primarily work with is NICU families and those babies, those parents who are taking a baby home after a NICU stay. We're stressing not only the importance of following up with babies' well checks, but mums too. A mother can't take care of a newborn if they're not implementing even the most basic self-care, and that includes taking the time to go to their own appointments. Families leaving the NICU often want to implement strict self-isolation measures at the best of times, but even more so during COVID. And this can be hard when a newborn needs to be seen shortly after discharge and at regular intervals thereafter. We have seen that families are spending even more time than usual trying to decide upon a pediatrician. Others have been exploring virtual options through telemedicine if they're wary about taking their baby out. But equally, they're fearful that if the majority of their appointments are held this way, that doctors may miss out on signs if anything goes wrong. And then if therapies are needed, parents feel even more of a burden to get this right. There may be limited in-person appointments available. They may choose virtual therapy again. And then the other alternative is letting therapists into your home. And that can be a difficult decision for NICU parents.
Yeah, definitely. Dr. Goldstein, what are your thoughts on the vaccine schedule disruption?
My thoughts are very much confined to that which pediatricians are seeing in the community. We're seeing a lot of families who are hesitant to go to the pediatrician because of the fact that they're worried that their child will be exposed to COVID-19. And as a result of this, there are two real problems. One is when you look at the disruption in the normal schedule, as previous speakers have elucidated, it seems that most children are starting to get behind as a result of the disruption in normal pediatrician visiting hours. But also, once we start to see an effective vaccine, and again, we can't prognosticate when that might be, but whether children are going to be getting this vaccine and how it will fit into the conventional setting. These are two issues which I think will be a real problem moving forward, because you'll see under vaccination and likewise increase in certain at-risk diseases, including measles, mumps, rubella, and other things that we really haven't seen in some time. And again, although we have a very prominent anti-vaxxer movement in this country, it is one of these things that has the potential to even be more of a concern as we have parents avoiding office visits, and as pediatricians have been forced to curtail visits because of risks for overcrowding in their office space.
Yeah, I know with everything going on with the COVID pandemic, there are so many lessons we're going to learn after the fact, and there's so much data that we're going to be collecting years down the road, and it's going to be very interesting to see, not only the economic impact, which people I think are feeling right away, but then what is this long-term impact on our public health in general. So I want to go to our last topic, and that is preterm birth reduction. So there was a very popular article in the New York Times just within the last couple of months that kind of looked at this potential reduction in preterm births. It was a pretty popular article that was going around. And it seems like there's quite a bit of anecdotal evidence suggesting that since the pandemic began, there has been a reduction in preterm births, specifically amongst those extremely low birth weight babies. So, Dr. Goldstein, I want to go back to you first. What are your thoughts on this, and are you seeing it in the NICU that you work in?
I think to answer this question, you have to say your mileage may vary. And in fact, it seems to be that this is what they're seeing on the East Coast of the United States and to some extent in Europe. There's a concern, because although we normally see an increase in the birth rate relative to certain crises that force people to be at home, this seems to be contrary. And it may be because people are effectively isolating themselves from one another, keeping good social distancing, but others are a little bit more concerned about what effect COVID might have on early pregnancy. And although, again, we're not seeing a lot of severe disease in babies who are born either preterm or term as a result of COVID, there is a question to those whether it, in fact, may decrease either fertility or an increased rate in early loss. And again, a lot of this data is anecdotal. There is not a lot of convincing evidence of either of these effects. But again, as reported in the New York Times and other venues, there does seem to be a decrease in preterm births, not even relative to those births occurring at term rather. So again, I think that when you look at some units, and again, I've spoken to some units and I've worked in some units where they don't seem to have a decrease in preterm babies. But at the same time, I've spoken to a number of people and seen it on a number of news outlets that in fact, this is a concern in various locations around the world. Once we have a chance to get through this pandemic and look at these trends and reconcile it with other factors, including the world economic picture, which again has been affected by COVID, I think only then will we come to a more complete understanding as what we're seeing.
Thanks for that, Dr. Goldstein. Any final thoughts on this topic? Becky, we can start with you first.
So I just want to reiterate what Dr. Goldstein just said, is that I think it's going to be extremely important that in the years to come that we have the ability to go back and look at this data and its relationship to COVID. You know, whether we like it or not, preterm birth is still a problem here in the United States. And if you look at the data that has been published through our vital statistics, you know, that problem continues to increase over the past several years here. So, you know, regardless of what the preterm birth data, you know, currently showing some of these initial reports, you know, we as clinicians, you know, we still have a responsibility to ensure that, you know, women are receiving education about preterm labor signs and symptoms, even more so because, you know, we've transitioned to some of our prenatal appointments being via telehealth. And so making sure that education is being given to patients on a regular basis, even more so as we spaced out some of their appointments as well. We need to, again, reassure patients, as was mentioned earlier, that it is safe to come in to our triage areas if they have problems and not to delay. And then looking at when these patients do come into our triage areas and are identified as having preterm labor, that we appropriately manage these particular patients according to what our current guidelines are.
Christine, any thoughts on this?
Well, what I would say is in terms of the preterm birth rate, I'm leaving that answer to the experts on this panel. But speaking as a parent representative, just to circle back to our conversations on mental health, regardless of whichever reason you have a baby in the NICU, something that we found over the last 6 months or more has just been the increased distress and strain on NICU parents. As I say, regardless of what they're in the NICU for, it's already a stressful environment. There are many additional worries and concerns that they're having to face. Additional sadness and loneliness, and the lack of empathetic connections with other NICU families. And if anything good comes out of this, I think it's the fact that mental health conversation has been brought to the forefront and is being talked about more, not just in the NICU setting, but overall.
I definitely agree with you there, Christine. Well, that's all the time that we have today to cover these 3 topics. So thank you to Christine, to Becky, and Dr. Goldstein for their time. We appreciate it.
Thank you.
Our next segment that we're going to cover is such an important one. And with recent events in our country over the last several months, we really have an opportunity to raise greater awareness about health disparities that disproportionately affect the Black community, including babies in the NICU. Earlier this year, the National Coalition for Infant Health put out a statement about eliminating healthcare disparities and ensuring patient-centered care for all. Dr. Mitchell Goldstein, who we just talked to a couple seconds ago, said as part of the coalition statement, quote, As healthcare providers and advocates, we must prioritize the elimination of all healthcare disparities, especially those affecting Black Americans, and ensure that our actions advance equality for all, end quote. So today I have two very respected and experienced leaders to help us understand more about this topic. We're joined by Janae Johns. Janae is president of Once Upon a Preemie and founder of the Once Upon a Preemie Academy. And Janae is coming to us today from the Philadelphia, Pennsylvania area. And we're also joined by Dr. Michael Young, a neonatologist, a past chair of the pediatric section of the National Medical Association. And Dr. Young's also an associate professor at Howard University College of Medicine. And she's coming to us today from the greater Washington, D.C. area. We will have time for a few questions at the end of this segment. So again, please have your questions ready and submit those at any time using the Q&A box under this live stream. So thank you, Janae. Thank you, Dr. Young, for being here with us. Dr. Young, I want to get started with you. Lay the foundation for us. When we look at outcomes in the NICU, what role do racial and ethnic disparities play?
Well, first, we have to consider the role that race and disparities play on the mother that produces this preterm infant or at-risk infant. Too often, the mothers may not have access, they may not have insurance, they may not have providers that can give them that care. They also may have a bit of stress, quite a bit of stress. And we've come to recognize that systemic racism in this country is a continual stress for African Americans. And so that the fact that we may see mothers of all socioeconomic levels still have at-risk preemies attest to that. We know that stress increases the risk for low birth weight, increases the risk for preterm birth, and increases the risk for infant mortality. And we add that to maternal chronic illnesses, diabetes, hypertension, and then personal issues like substance abuse. That puts the baby at risk. And the outcomes for these infants are dependent, of course, on how preterm they are, but also how their mothers are treated, are cared for, and how the babies are cared for by the physicians and nurses that treat them.
That is such an important point that you made, that it's not just about the babies, but it really starts with the mother. And so I'm glad you brought that up. Dr. Young, I want to stay with you. Can you talk a little bit about implicit bias? You know, what is that? And how does it play a role in the care of these mothers and babies?
Well, implicit bias is, that we like to say, it's unintentional discrimination against a person or an individual based on, race, gender, sexual orientation, whatever may be the challenge that the person who has the bias or doesn't realize they have the bias is having. But there's an underlying bias in this country, generally speaking, that if you are less than, if you are not white and you're not well-to-do. And that permeates this country, and it's something that we need to deal with. How does it impact preterm infants? There is a recent article that was in the proceedings of the National Academy of Science that indicated that newborns, Black newborns, are more likely to die when the physicians that are caring for them are white. And when they look through that data, and I haven't seen all of the intimate data myself, but there wasn't anything particular or directed to the care of the infant that one could put their finger on. But when we look at how babies are handled by staff, the regard for this infant, just to speak to the baby and caring for him and looking at him, talking, that baby talk that happens, that usually happens for a caregiver. If that person is dismissive of the mother and the baby, because of their subjective bias. They may not consider that to be a big thing, but they may not encourage that mother to breastfeed. They may not handle that infant appropriately. They may not offer innovative mechanisms of care. And they don't see it as being structurally a problem, a direct problem to that infant, but it's there that discriminates against the care of that baby. The data is very clear, and it's very striking that that is still the case in this country.
Janae, I want to go to you next. Do you have any, and I'm asking you this because I know you do, you've had a personal experience with these biases, so I'm curious if you can share that experience with us.
Sure, and thank you for having me, Susan. And I'd also like to thank the members of the Summit Planning Committee for organizing this panel, especially given the global outcry against racial injustice in our country, as Julian reminded us, as we continue to experience history repeat itself here in the United States. And you're right, Susan, unfortunately, I did experience many of the biases that Dr. Young just referenced at an institutional level. There was zero diversity, or I should say virtually non-existent diversity among the NICU staff when our family experienced the 3-month stay in the NICU. I remember my son and I's second kangaroo care experience, or skin-to-skin contact experience, and the director of nursing came by our bedside and she asked me, "Are you a doctor?" And I said, "I'm not." And she asked if I was a supervisor, and I said, "I'm not." And she said, "Well, what do you do?" And I said, "Well, I'm a director at the National Medicaid Managed Care Organization." And she said, "People like you don't fare well in the NICU. So I'd encourage you to build a relationship with the respiratory therapist. She's an African-American professional like you." So there was already an assumption and a stereotype placed on me because upon entering the NICU, I was curious, I was concerned, and I was traumatized. And I wanted to make sure I could speak the NICU jargon and language, and I wanted to make sure I could be the best advocate for my son and ask a lot of questions for things that were unclear. And I thought I was just being a concerned parent. But in the NICU staff's eyes, I was too educated, I was over-opinionated, and I was speaking out of turn, if you will, because I was just trying to be the best advocate for my son. And so those experiences, coupled with others, including there not being emotional and mental support groups available for the families in our NICU. My son was born in one of the lower SES hospitals, or NICUs, within a larger hospital system in our area. And the Black moms and I noticed that the other NICUs had ample resources and supports for the NICU families and parents, and ours didn't. And that bothered us. On an implicit bias level, I recall a nurse referencing the texture of my son's hair changing and them not knowing what to do with it during bathing time, and so that will become my responsibility. And whether that was intentional or not, it was highly offensive, and the texture of my son's hair was the last thing that I needed to be worried about when I needed to leave my baby in the care of these professionals who I needed to trust. And so these experiences, coupled with others, left me feeling even more traumatized, frustrated, discriminated against, so much so that I started to research the process of transferring my son out of that NICU to receive care in another hospital in our area.
Thank you for sharing those experiences, Janae. And it's by sharing these experiences that we can have a bigger conversation, and we can try to help implement proper training, and we'll get to that a little bit better so that we can kind of remove some of those barriers to the quality of care that every single baby and every single NICU family deserves as well. So this question is for both of you, and Janae, we can start with you and then go to Dr. Young. How would you counsel or advise healthcare providers on ways in which they can avoid making some of these same mistakes, which some may be intentional or not, but that you referenced, Janae? What would your advice be to them?
Thank you, Susan. That's a great question. And that's a question that I wished I were asked during the time of my family's NICU stay, because I was responsible for leading health equity, health disparities, and cultural competency training programs and services for one of the nation's largest managed care organizations. And by virtue, we had to deliver these training programs and services to the providers in our network. And so my advice for providers to avoid implicit bias when delivering care to racial and ethnic minorities would be to participate in complete, routine and continuous racial and ethnic health disparities, health equity, and implicit bias training. This is something that I believe is very important, not just on an individual basis, but as a clinical community and as a unit and team to improve the quality of care that's delivered to all families. And this is one of the driving forces that led me to create the Once Upon a Preemie Academy, which is a virtual training program that will provide health and racial disparities or health and racial equity and implicit bias training specifically created for the neonatology professional community. These training programs are widely available. There are ample cultural competency training programs for doctors and nurses and social workers and anyone touching a NICU family, but there's none specific for the neonatology community. And so, as Dr. Young referenced, research shows that when non-minority professionals deliver care to minority patients and families, treatment differs. There are communication challenges that arise and implicit bias creeps in. And this training academy is one of many steps that I believe that providers in the healthcare community can take to avoid it altogether.
Dr. Young, your thoughts?
Well, I would start with a rule of medicine I was taught, and that is to listen to your patients. Too often, women in general in our culture tend to be dismissed. We talk too much, or we're not on the same page as the male thought process. So when we talk, our thoughts, our concerns are often dismissed. So the first thing is to listen to patients, genuinely listen to patients. I think implicit bias training and cultural competency training is important, but it shouldn't be just one thing that's checked off. Too many of the programs have that people attend or go to have no reference on how they impact a change, and it's just something that gets done because that's what the Joint Commission or the resident program says they need to have some training, and it's not very effective because there's no change in the individuals. So, but I don't say forget that. It should be addressed. It should be addressed appropriately, but it should be addressed in a proactive manner in order to seek a change and to recognize that human beings of all cultures need to have their presence accepted and recognized, and that's the first and basic component, and you build on that.
Excellent. Janae, what advice would you have for NICU parents? They're in the NICU, they're struggling, they're not quite sure, how can I advocate for my infant? What is your message to them? How can they be better advocates?
Thank you, Susan. It's the exact same answer that Dr. Young just provided for the providers, which is to speak up, speak loudly, and speak often on behalf of your baby until your needs or your concerns are addressed and recognized. I'd also empower NICU parents to seek resources outside of their NICU if it's not available or if it's not what you need. It doesn't meet your language, it doesn't meet your culture. There are ample NICU serving parent-led organizations, many of them are part of the summit today, where we look for NICU families to provide resources and services and to share our stories with to help prevent and avoid what we had to experience in the NICU. And lastly, I'd advocate for and empower parents to use their voices on patient satisfaction surveys. I think that is a very underutilized tool and resource that many parents ignore when they're leaving the NICU or leaving the hospital, because there's so many other important things that need to happen with the baby. But share your experiences and your stories in patient satisfaction surveys, because they do carry a lot of weight.
Thanks for that, Janae. We will have time for a little bit of Q&A after this, just as a reminder. So if you have any questions for Janae or Dr. Young, go ahead and put those into the Q&A box now. But I have one final question, and I want to give both of you an opportunity to answer this. So Dr. Young, we'll start with you. With so much going on around the country right now, this seems like an opportunity where we can raise greater awareness about what is happening to these mothers and to these babies. What can we do as advocates to elevate the conversation and to make a positive change? Dr. Young, we'll start with you.
Well, I think advocates we would be helped by advocates asking that medical training, medical professional training, not just physicians, but nurses and allied health as well, have covered the issue, require the covering of that issue in professional schools and in a focused and robust way, not just in a segment to finish. And when I say professional schools, I'm talking about the medical school, the nursing school, allied health schools in the beginning and under an ethics program that they should be having ongoing along with their clinical skills and their basic science education. The ethics has to be there, and there should be challenges to them on a seminar and clinical case basis so that people can work out in real time how they would manage different challenges. And we have too many of them available for us for clinical scenarios. So there's no excuse for it not to be there. It is the backbone of medicine, really, is to communicate with the patient so that you together can make appropriate diagnosis to help the patient out. And that's a holistic approach. It's not just what's wrong with your liver. Your liver is in your body, and it is functioning to help your mind. And all of that together needs to be mandated as part of the training. And I think people from the outside, the public, requiring schools to include that in curriculum would be very beneficial.
Janae, your thoughts?
I would encourage us as advocates to join the movement. There are so many movements happening across the country right now, sitting in our silos and bubbles, keeping all of this rich knowledge around what we know needs to happen to support infants and Black infants, specifically in the NICU. It would just be a very powerful partnership opportunity for us to join forces with the trains that have already left the station, one of which being the Alliance for Black NICU Families that you'll hear about in a moment. But in addition to getting involved in the many movements around the country to fight against racial injustice and to eliminate disparities in our country, I'd encourage us as advocates and professionals to listen to the voices of families that have been impacted by COVID, who have lost jobs or no longer have access to full service grocery stores or pharmacies because of COVID's impact or the looting and rioting happening in our country. Listen to the families and communities that have been impacted unfairly around police brutality, because these are the families that we're serving in the NICU pre, during, and post. And we need to have a better orientation and understanding of the global context in which our families and our patients and our babies are showing up. Lastly, I'd encourage everyone to enroll in the Once Upon a Preemie Academy to not only continue this conversation around health and racial equity in the NICU and how to support infants and families, but to get real-time solutions and tools that you can take back and implement in your various institutions.
Thank you, Janae, and thank you, Dr. Young. We've got a couple of good questions, and we have time for probably just 2 questions. So the first one is, how do language and cultural barriers impact the care received by communities of color in the NICU? Dr. Young or Janae, either one of you can take this.
Well, they embarrass communication if the organization has not been committed to doing cultural competency. So we know that patients come, and you know your patient populations, they come with different languages. It is incumbent and actually required that those hospitals have a means to translate, whether it's a face-to-face translation or a an automatic one. We have services that we can call on another line and be willing to engage that third party to do the translation. And don't suck your teeth and roll your eyes when you have to go through the phone. You should do it willingly. It's more than just having the capability. It's also how one's attitude is when you have someone who is not speaking the predominant language in this country. And it's so unfair to try and piece things together and mumble or pretend like you understand. And the patients, because they are too often in a different culture, will just nod because of the fear of reports if they're here without appropriate papers, or just don't want to face the embarrassment. They'll just nod and agree, and you're not communicating with them. It's a disgrace, and it should be addressed quickly and formally by the organization. It should not be a lag at all.
Dr. Young, I loved what you said there. It's not only the ability, but it's the attitude at which you approach that I think is so important. I love that you said that. Janae, was there anything you wanted to add to that?
You know, as hard as it may be, sometimes as professionals, I think it's just important for us to place ourselves in the shoes on the other end, or the other end of the receiving table of what we're giving out. And so if a hospital doesn't have telephonic or language interpretation services, they should certainly have a department with bilingual staff that can make those resources available to families, and check in with those families and ask what additional resources and services they need to receive adequate care, especially if and when their babies are in the NICU.
Okay, we have time for one last question. Janae, I think you kind of touched on this a little bit earlier, but it's please discuss the normalization of stress due to racism and how we can help women recognize when they experience it for reasons that they may not even recognize. Janae, do you want to take that one?
That's a great question, Susan, and it's one that's very loaded because in some communities and in some cultures, those stressors may show up in ways that are culturally acceptable for us to address and acknowledge at that time. Specifically speaking, as an African American micro-preemie mom, I experienced a fair share of anxiety and other emotional disturbances that didn't show up until 4 years post my son's NICU discharge. And so I had to normalize all of that trauma and all of the stress that I faced before I showed up to the NICU, during the NICU, and even my son's first few years after the NICU. And so now is the time in our country, with everything happening around COVID and the civil unrest, to talk about what you're experiencing mentally and emotionally and unpack how those stressors may be impacting you. Because at the end of the day, especially as preemie parents, our babies need us, and they need us in ways that no one else can give that care and that comfort and that nurturing. And so I'd encourage parents and professionals to help seek out those resources, community level resources, community health navigators, PREMATUREs, people who can help provide the support or path forward for someone who's overly stressed due to everything that we're facing in the country at this time.
Dr. Young, is there anything you want to add to that?
I think Janae has hit it on the head. The the one challenge we have is really recognizing this, really recognizing that the stress is not normal, because it's such an integral part of what we face every day, and helping us to recognize that we do not have to carry all of the challenges, that we need to speak up and force situations around us to change, also is the big challenge, because it's pushback from the larger community that doesn't think that the stress that we are talking about, or that the stress that we're experiencing, actually exists. And this unrest in this country right now, it's unrest for others. It is something that we've lived with, and it's an opportunity, I think, for the greater community to understand the kinds of not just implicit bias, but actual acting out on that bias that costs us our health and our lives, can be addressed in a better way.
Well, thank you so much, Janae, and thank you, Dr. Young, for taking time to talk about what is a very, very important topic. We need to elevate the conversation on this. We need to use some opportunities that have been placed before us in order to make the right kind of change that will allow every baby and every mother access to the best care possible. So thank you so much for joining us.
Thank you.
Thanks, man.
So following on the discussion we just had about healthcare disparities with Janae and Dr. Young, our next guest is here to tell us about her own experience dealing with these biases, but to also introduce us to a new organization that was formed earlier this year, the Alliance for Black NICU Families. So I'm happy to be joined by Ashley Randolph Cooley. Ashley is a patient advocate. She's founder of Glow Preemies, and she is a co-founder of the Alliance for Black NICU Families, and she joins us today from Sacramento, California. So Ashley, thank you so much for joining us.
Thank you so much for having me.
Yeah, so first off, quickly tell us about your connection to the preemie community.
Yes, so I am the mother of 3 children born premature. They are now the ages of 9, 6, and 5 years old.
Okay. And just for everybody watching, can you tell us about the crown? I know about the crown, but tell everybody else about the crown you're wearing.
So I am Mrs. California United America, and so I use my platform to spread awareness about racial inequity in the NICU.
Excellent. So we just had this great conversation with Janae and Dr. Young about this, and Janae shared some of her own personal experiences dealing with this, but you've also had your own very difficult experiences facing biases and racism in your experience. So can you tell us a little bit more about that?
Of course. So unfortunately, I suffered severe hyperemesis gravidarum with all 3 of my pregnancies. And because of that, I was released from every doctor that I had during my pregnancies because they viewed me as a risk. I also had to advocate for the proper medical care for my children and myself during the pregnancies and during my NICU stays.
So you've taken some kind of negative experiences that you have had, but you've turned them into a positive, which is a theme that we're hearing from other people who have spoken to us today, especially as parent advocates. They're doing that. So can you talk to us, and you referenced this with the title that you now hold in California, but can you talk to us about how you've taken some of these negative experiences and you've turned them around in order to help other people?
Of course. So I started Glow Preemies in 2014, and we support and empower families with children in the NICU. I also released a book about my experiences, and also just recently co-founded the Alliance for Black NICU Families.
So that's really what we're kind of here to talk about today, is this new organization that was founded earlier this year. So talk to us a little bit about what this organization is. What are some of its goals, priorities? Who's a member of this organization?
Yes, so majority of our members are African American premature parents of NICU children who experience their own racial inequity and experiences. Majority of them already have their own support group or resources for NICU families, and together we collaborated to bring resources to NICU families and to also make changes in the perinatal and neonatal area for racial inequity across the country.
Okay. Where can those listening go to find out more information about this new organization?
Yes, you can find more information at blacknicufamilies.org and glowpremies.com.
Okay. Ashley, thank you so much for taking a few minutes to join us today to tell us about your own experiences, what you've done to try to positively impact other families so that they didn't have to deal with those same things. And also thank you for founding this great organization that is really dedicated at providing resources and support for our Black NICU families. So thank you, Ashley, for joining us.
Thank you so much for having me.
The final segment of today's summit is Congenital Gut Disorders, Research and Reality. We have learned so much over the last several years about how human milk is medicine, and today we're going to explore that in a little bit more detail as it relates to congenital gut disorders, or CGD for short. So I'm happy today to be joined by Katie Trudeau. Katie is a NICU parent and a mother of a son who was born with a congenital gut disorder, and Katie's coming to us today from the Baltimore, Maryland area. We're also joined by Dr. Martin Lee. Dr. Lee is Vice President for Clinical Research and Development at Prolacta Bioscience. And Dr. Lee comes to us today from the greater Los Angeles, California area. And lastly, we're joined by Dr. Heidi Karpin, an associate professor at Emory University Children's Healthcare of Atlanta. Dr. Karpin is also the lead investigator in a clinical trial about human milk and babies born with congenital gut disorders. And she's joining us today from Atlanta, Georgia. So thanks everybody for joining us for this discussion. Very interesting topic. We're going to be learning a lot here today. But Dr. Lee, I want to start with you. First off, set the stage for us. For those who don't know, what are congenital gut disorders?
Certainly, Susan, and thank you for having me. Well, as the name would suggest, they're disorders or abnormalities at birth. They're birth defects that involve the gastrointestinal tract, and they usually result in intestinal obstruction, which can cause problems with feeding and so on. But I want to focus in on three particular ones of these disorders, and those are gastroschisis, omphalocele, and intestinal atresias, which happen to be the subject of the clinical trial that you mentioned that Dr. Karpin and I are working on. Now, just to make sure everybody understands, because these are fairly rare disorders, we'll mention that in a minute, but gastroschisis and omphalocele are situations in which there is a hole in the baby's belly and the intestinal tract is poking out, and literally in the outside environment. In omphalocele, the intestinal tract is covered by a sac. In gastroschisis, it's not. And atresias are basically situations in which there is a narrowing or actually a disconnected, as you can see on the screen now, a narrowing or disconnected section of the GI tract. And in all three cases, they need to be repaired by surgery, which, of course, for a newborn is a major issue. And I point out that a good percentage of these babies are actually preterm babies.
So Dr. Lee, let's continue with you here. What do we know about their prevalence? How common is this?
Well, these are pretty rare disorders. As you can see from this slide, it's somewhere between 1 in 2,500 for gastroschisis babies, up to 1 in 4,000 for omphalocele babies. Not to put that in a proper perspective in case those numbers, don't resonate. There are roughly about 4 million babies born every year in the United States. And so roughly we're talking about a few thousand babies a year that have one of these kinds of disorders. So this is pretty rare. And as a result, not a whole lot of people know about these. But the point is that they warrant a lot of attention, certainly in the ICU, and certainly, as I said, involving surgical repair and long-term care in the hospital and beyond.
Dr. Carpin, I want to go to you next. What are some of the short-term and long-term impacts to these babies who are born with congenital gut disorders?
These infants often have multiple surgical procedures. Some of these infants actually have more than one congenital gut disorder existing. Like, for example, a gastroschisis baby may also have necrotizing enterocolitis, which you've heard about in premature babies, happens actually more frequently even in infants with gastroschisis than in the tiniest preemies. And often they may have intestinal atresias, which can be a subset of patients on their own, but can also exist in patients with gastroschisis. And these patients often have stage closures of their abdominal wall defect and often multiple surgical procedures. They obviously cannot eat during this protracted period of time, and so they need central IV access for IV nutrition called parenteral nutrition, which has its own inherent risks, both the central line for risk of infection and long-term parenteral nutrition for its effects on the liver and ongoing liver disease as time goes on if they're on TPN for a long time. They also have feeding intolerance and feeding interruptions, often multiple times of on and off feedings as their intestine is starting to try to do its job of digestion and absorption. And as I've mentioned before, certainly infections both in that central line, but also in their intestine can happen at any way along their course, including very close to the end when you think a baby is almost ready to go home. And long term, these infants often can lose significant stretches of their intestine to things like necrotizing enterocolitis or an atresia. And they can end up with short bowel syndrome, which leaves them with the inability to maintain their own growth through nutrition that comes through their intestine, and may often have to be on IV nutrition for months to years. And obviously that puts them at risk for long-term growth issues. They have an increased risk of food allergy, which is really more the rule than the exception in these patients, and neurodevelopmental impacts, both of being sick babies in a NICU and also some associations between things like gastroschisis and autistic spectrum disorder conditions. So these are very complicated infants. We often talk more about the preemies, but I have a particular interest in these larger, sick surgical babies because I think that they really have not had the benefit of human milk other than their own mom's milk and of research into their nutrition and the best nutrition for them to recover from these surgical disorders.
Katie, you have a firsthand experience. Your son Camden was born with a congenital gut disorder. So tell us a little bit about your experience with that.
Hi, everyone. Thanks so much for having me here today. Really, truly, our story kind of started at our 20-week ultrasound when we found out that our son Camden did have some type of abdominal defect. We weren't sure what it was at the time. But after investigation and taking myself and my husband to specialists, we were diagnosed with gastroschisis, and really explained to us, just like Dr. Carpin and Dr. Lee said, his intestines were growing on the outside of his body during my pregnancy. There was a tiny hole in his abdomen, and overall, I had a pretty uneventful pregnancy, other than, of course, the back and forth to doctor's appointments and checking on him and checking on his progress. But it was decided to have a C-section at 38 weeks gestation. So on August 14th, we had a baby boy. He was 8 pounds, so he was definitely a bigger preemie, and he was able to have the primary closure surgery the day that he was born. It was very stop and go while we were in the NICU, and really I think that our biggest challenge was the time that it took for his gut to heal between the feedings and, getting him, stabilized as a typical newborn on top of having gastroschisis. Once we got home at about 16 days, which is truly phenomenal for these babies. But, we were just noticing that he was having awful, reflux and vomiting a lot. And, as a new mom, you're already on edge. You're already not certain of things. And for Camden, it took an incident where he had a very horrible day, and he projectile vomited. And of course, my husband and I ran him to the emergency room, and we landed a 5-day stay in the PICU. Did not require surgical intervention, but really, truly, bowel rest and the slow feeds were key.
Okay, Katie. I think we might have lost Katie for a second, but she's really talking about a lot of the challenges that Camden was facing, and one of those that she talked about was feeding. So Dr. Karpin, can you talk to us a little bit about how these babies are treated? Do they always end up in the NICU or the PICU?
Hopefully, at least in the beginning, they all end up in a NICU, and they need to really be in a highly functioning level 3 surgical NICU, if not a level 4 quaternary care center at a major children's hospital that has all the subspecialty services available to them. Because many of these babies also have problems with, as I've mentioned, with their liver. Some of them have short gut and need a GI specialist as time goes on, infectious disease for infections. So her stay in the NICU of 16 days plus a little bit in the PICU is incredibly short. The average length of stay for a gastroschisis is 4 to 6 weeks. And it's often easy to get the bowel reduced into the abdomen. The trick is getting it to function, and that is something that you have to wait. You cannot force it, and that infant's intestine has to have the time to adapt and develop motility and restructure itself on the inside of the body and start to function to do its job.
So, Dr. Lee, this is how we're going to make the connection now. So I kind of preface this by saying human milk, we're finding out, is medicine for so many things. So you work with a company called Prolacta Bioscience. So tell us now about this potential connection between human milk and CGDs and why Prolacta is expanding its research into this area.
Well, thank you. Yeah, it's a good point. I mean, we have spent a good part of the 20 plus years that Prolacta has been around working with the proper nutrition based on human milk for premature infants in the NICU. And Dr. Karpin came to us a few years ago and said, well, we have these babies. There aren't that many of them, but we think that they can benefit. We think they can benefit from a human milk diet. And we thought about it and really didn't hesitate for a second. Even though, as I said earlier, there's very few babies that are born every year, said in the few thousands in the entire country, we knew that our human milk products, our fortifiers, could potentially help. But we also realized that the products that we make for the premature babies, the ones that are born at say 27, 28 weeks, that may be of some value to these infants, but some of them are born at near term, or these babies start to grow while they're in the NICU and get to a point of being term babies, but still can't go home. So we actually developed a new fortifier that would be a specialized fortifier for these types of babies that are undergoing surgery, that are still needing nutrition because they can't feed They can't eat. They can't intake as much nutrition as they need. So we produced this specialty fortifier that we knew would help, in spite of the fact that, you know, it wasn't as if this was a massive new opportunity for Prolacta. It was just the right thing for us to do.
So Dr. Carpin, tell us a little bit about the clinical trial of which you know a lot about, that's really looking at how human milk might impact these babies.
We started this trial, one of my surgical colleagues and I, back in 2015 with a medical student, because we were frustrated that we were seeing quite a lot of complications for gastroschisis babies and intestinal atresia babies in particular, who were fed formula. And so the first thing we did was to just perform a retrospective review of infants over a 3-year period of time in our own NICU, looking at babies with a variety of early acquired and congenital gastrointestinal disorders, and looking just at what they were fed and how they did. And when we looked at that data, which is published in the Breastfeeding Medicine Journal, we found that infants that were fed 50 to 99% human milk, which was all from their mothers, because these babies are too large to qualify by most protocols for donor milk, and infants that received 99% or greater, basically an exclusive human milk diet, their mom's milk, were faster to achieve full enteral feedings. They, as you can see here from this data, time to full feeds between the groups was on average about 10 days sooner. Days on IV nutrition obviously follow along with that data about time to full feedings. And what's really remarkable is when you look at the length of hospital stay, 10 to basically almost 20 days sooner out of the hospital for these infants, which is a huge difference for these families, huge difference in cost to the medical care system. And these infants also had decreased risk of infections, of necrotizing enterocolitis, and also markers of liver damage. Their direct bilirubins were also significantly lower. And this really galvanized us to start to think about a prospective trial where it's really an intention to treat, because no one would have really the equipoise after this data to want to randomize babies to receive formula versus a human milk diet, knowing these risks. And so we reached out to Prolacta, who were very interested in partnering with us for this study. And as you can see on my next slide, we started the prospective arm of the human milk for CGD trial. And this trial is ongoing now at about 22 centers around the country, large children's hospitals that treat these type of babies. And our goal is to enroll a minimum of 100 infants with gastroschisis, omphalocele, and intestinal atresias who are not preemies. They are greater than 1,250 grams, greater than 32 weeks gestation, who were admitted to a study NICU. And this is key because if babies are born at less than 1,250 grams and less than 32 weeks, which is fairly unusual for this group of patients, they would qualify for most protocols for donor milk if mom didn't have enough milk. And we really wanted to target the babies who didn't have that advantage. And these babies are fed an exclusive human milk diet, which is comprised of mother's own milk, which is our first priority in helping these moms get started pumping and sustain pumping throughout the course of their baby's time in the NICU, hopefully to go home breastfeeding. But to offer them pasteurized donor human milk from Prolacta if the mom didn't have enough human milk of her own. And what's different than really the way that most of these babies have ever been treated is that when the babies reach about a third of the way up to their full goal of feedings, they're fortified either with Prolact Plus, which is for infants who are less than 37 weeks or less than 2,200 grams. So preterm and late preterm, or a new product called Surgifort, which was formulated by Prolacta for infants greater than 37 or equal to 37 weeks and greater than 2,200 grams. And what's interesting is this shift in paradigm for both my colleagues and others around the country to understand that these surgical babies have very increased needs for both calories and protein intake that they cannot meet with mother's milk alone. And so fortification really is important to provide them that extra protein and calories to help them heal and have enough left over for growth and development. That brain is growing fast, and so is the rest of the body. And if it has to heal multiple surgical wounds after several surgeries, there's not a lot left for the growth of other vital organs. And so we'll be comparing some of the same things: time to full enteral feedings, days on parenteral nutrition, length of stay, growth parameters. And we'll be looking at the retrospective cohort from each of the hospitals that are involved in this study as a comparison group for infants that have received formula as part of their diet against these infants who are and have been receiving exclusive human milk.
It's fascinating. So thank you so much for talking about all those little details. It's just incredible, truly, what human milk really is, and it is medicine. So if we still have Katie with us, I think she was having some issues a little bit earlier. Katie, I just wanted to hear from you a little update about how Camden is doing today.
Hi, my apologies. Cam is doing great today. He just turned 7. He's in 2nd grade. He enjoys football, four-wheeling. He likes to go camping, and he eats absolutely everything. He's luckily a kiddo with not any allergies. So, you know, we really feel blessed and fortunate that we are where we are today with all that he's been through.
And thank you for sharing that story. And I know it was a challenging time for your family, what you went through. Dr. Lee, I want to finish it up with you. We're learning so much about how human milk really is medicine for a variety of conditions. Just elaborate for us a little bit on that.
Sure. And as I mentioned, Prolacta's been around for about 20 years, and I've been there for just about that entire time. And when we first thought about how the company and how Prolacta was going to help, we realized at first that our primary goal was to look at the extreme preterm infant, as I say, the babies that are born 27, 28 weeks, because first of all, we all, I think, recognize, everyone that's here today, everyone that's listening today, understands that human milk is the best medicine and the best nutrition for a baby that's born both premature and, of course, even babies that are born at term. It's what nature intended. But certainly in these severely ill individuals, in these babies that are born so early, we recognize we certainly, our mission has always been to support these babies from the best nutrition that, again, nature intended, that we're just helping along. But as we proceeded in the development of that, as you've heard today, talking with Dr. Karpin and how human milk is so important to these babies, we recognize that such a precious resource as human milk, and all the women who graciously produce the milk and donate it and provide it for these babies. It is incumbent upon us to make sure that as many babies as possible, as many infants, regardless of whether they're extreme preterm, or even term babies, with whatever issue that they have, which necessitates the best possible nutrition that they can receive. It's always been incumbent upon us, regardless of how few or how many of these babies there are. It's our mission to make sure that every baby gets fed the best way possible. And so that's what we've been all about since the beginning. And I think this study that Dr. Karpin has been talking about in congenital gastrointestinal disorders is just an illustration of what we at Prolacta, our reason for existing, for our reason for coming to work every day and doing what we do. This is just a prime illustration of that. And as you said, Susan, it's medicine. It's not just nutrition. It's the best medicine And we live by that credo every day. So thank you.
Great. Well, I'll look forward to maybe at next year's summit or the one after that, getting an update on where we are with the enrollment of the trial, what the results are looking like. It will be very interesting to see how this might benefit these babies with CGD. So Katie, Dr. Carpin, and Dr. Lee, thank you so much for being here with us today.
Thank you for inviting us.
Thank you. Thank you.
So this brings us to the close of the 2020 Infant Health Policy Summit. Again, this was a little bit different than in years past. Usually we convene at a great space in Washington, D.C. We're able to bring everybody together, but of course, that wasn't an option for us this year. But I know that us being able to do this virtually has allowed us to broaden our reach. We have been able to have people from other countries who are joining us today via the internet, and so it's just provided a real opportunity to expand our messages, and we hope that everybody has taken something from this today. There have been so many interesting themes that we've talked about. One thing that really sticks out to me is that we've kind of reached an inflection point in the country for a couple of different reasons, where we have an opportunity to elevate the impact that we could have on infants and their families. You know, because of COVID, we have an opportunity to talk more about other respiratory conditions that are very dangerous for infants. Obviously, with much of the civil unrest in this country, it's an opportunity for us to talk about how can we better provide care for ethnic minority babies and their mothers and their whole family. It's not just about the baby, it's about the mother as well. So I certainly have learned a lot today, and I hope you all have as well. So I want to thank all of today's participants for their insights, for their time, and I want to thank everybody who joined us from around the world today. To learn more about the National Coalition for Infant Health, many of the topics that we've discussed today, please visit infanthealth.org. Thank you so much for joining us, and I hope you have a great rest of the day.